What do you do when you've failed PPI therapy and you've got a negative H. pylori test, or you've treated for H. pylori and the patient's still got problems? Well, there's a number of scenarios here. You may have mild symptoms with mild breakthrough rather than a true PPI or antacid failure. And with those patients, I would suggest reassurance and lifestyle. Or you can make a positive diagnosis of functional dyspepsia, and perhaps functional dyspepsia is a subject for another podcast at some point, and consider a different approach such as stress management, IAP referral, low-dose tricyclics, for example. Obviously exclude other diagnoses and do relevant tests such as ultrasound, as we've discussed, or your options are direct open access endoscopy or a secondary care referral. Now, we do about 1,500, 2,000 direct or open access referrals in Sheffield. Common questions we get asked from GPs after the open access endoscopy is mainly about histology, actually, but sometimes about the reports. And what I'll do is I'll go through some common questions and issues that are often raised. So first of all, of note, most endoscopies show no significant pathology, although we do find a hiatus hernia very common in up to a third of patients. And unless very large, greater than 5 centimeters, hiatus hernias by themselves are not usually a cause for symptoms. They just may contribute as a risk factor for reflux. And another thing's often reported is grade A esophagitis or grade B on the diagnosis. And this is a where you have less than 5 millimeters streak of inflammation. Now, these grades of esophagitis are not diagnostic of reflux, but a patient reads that and sees esophagitis, and then they are convinced they've got a pretty unpleasant condition. And in fact, it's part of the realm of normality. So grade C and D esophagitis, which is where you have sort of confluent ulceration or extending beyond 5 millimeters of inflammation, is quite diagnostic of reflux. And I guess the other thing to remember is endoscopy is not a treatment. People don't get better with endoscopy, and it does not provide sustained reassurance to the anxious patient in the long term. So we do get a number of repeat endoscopies done, and often it's because the patients have the same symptoms, but they've got more anxious about them. Have we missed something? And I guess the doctor may be anxious as well. Have you missed something? But almost invariably, the repeat endoscopy is generally normal unless there's been a change in circumstances or symptoms. So don't repeat endoscopies for reassurance, is the message there. Barrett's is very much overdiagnosed by endoscopists and by histopathologists. If you've got a less than 1 centimeter Barrett's seen at endoscopy, biopsies have often been taken of the gastroesophageal junction, and unless intestinal metaplasia is seen, this has little clinical significance. It's not a high risk for esophageal cancer. It's a very, very low risk. And these patients actually, with our current secondary care guidelines, should not even be biopsied or reported as Barrett's, but they still do. And the histopathology report will report columnar epithelium in keeping with Barrett's. Now, that can lead to the patient having unnecessary anxiety, surveillance, long-term PPI therapy. So particularly if there's no significant heartburn history, it may be worthwhile asking for an opinion, advice and guidance rather than labeling the patient with Barrett's. Often we will report the histology from open access if it says Barrett's and give an opinion on that. But just to be aware, Barrett's is a diagnosis both from the endoscopic appearance plus the histology plus the clinical scenario rather than any one of those alone. Okay. There is no role for endoscopy for patients with typical reflux symptoms that respond to PPI medication, even if they relapse, which is usually related to rebound hyperacidity when weaning hasn't occurred. You should really concentrate on a lifestyle approach. And I guess this reflects that there is no current role in the UK for Barrett's screening endoscopically, except for selected cases for perhaps a long history of reflux symptoms, more than 10 years in males over 55, or people with a family history of esophageal cancer. It may well be there'll be primary care screening in the near future with the cytosponge, which is a less invasive test. But for the moment, looking for Barrett's is not recommended. What I would like to plug is my interest in eosinophilic esophagitis, which is an allergic condition of the esophagus, which is the commonest presentation now is food bolus obstruction. It's more common in young atopic people, particularly males with asthma, hay fever, eczema. And these patients may sort of pitch up on open access from time to time. A lot of them will come with dysphagia on a 2-week wait pathway, but sometimes they do not get an esophageal biopsy done, and they'll be referred back to you, and the patient will be knocking your door saying they're still having problems with their swallowing. If we've failed to take an esophageal biopsy, they do need referral back for an esophageal biopsy to be done to make the diagnosis. And another catch out, which can occur with the less experienced endoscopist, is sometimes EOE looks like candida infection of the esophagus, and of course these patients may be on an asthma steroid spray, and if there's no histology taken, you haven't proven candidiasis, and this could still be EOE, they will not respond to fluconazole. And of note, esophageal candidiasis does not cause dysphagia or food bolus obstruction. It causes odynophagia or pain on swallowing, particularly hot or cold liquid. So there's just a clinical tip from that point of view. So in terms of some other sort of histological type questions, often you'll get a D2 biopsy taken, very common in Sheffield. We have an interest in celiac, and often D2 lymphocytosis is reported. Now, there is an association with celiac in up to 16% of cases, so it is wise to check a TTG celiac antibody, making sure the patient's on a gluten-containing antibody diet. This lymphocytosis can also be associated with the presence of H. pylori or non-steroidal use, but if they're not in place, then often this has no clinical context and can be ignored, but it does cause some anxiety. It is common to see random gastric biopsies taken to exclude H. pylori and a report of reactive gastroscopy given. This is a common finding in the hostile environment of the stomach, and it has little significance in the context of a normal endoscopy or only mild gastritis seen. It is quite common to see a bit of mild gastritis in people without symptoms or problems. The other thing we often get asked about or causes a bit of concern is gastric polyps are pretty common nowadays, particularly in people on long-term PPIs, and they're usually fundic polyps, and they're not associated with progression to cancer, unlike colonic polyps. So generally they can be ignored, and don't worry about those. If we do see a funny looking polyp, we will usually biopsy that. And if it's an adenoma, then it does need removal, and we'll usually manage that from secondary care. I guess one of the last things just to comment on is the presence of intestinal metaplasia on a gastric biopsy. This can carry a gastric cancer risk if it's widespread throughout the stomach and is associated with gastric atrophy, no folds to see, or the patient has pernicious anemia. If that's the case, they probably do need a referral to secondary care, either for surveillance age 55, we do 3-yearly endoscopy, or an assessment of their risk factors. If there's a bit of intestinal metaplasia focally just in antral biopsies, that really has no significance and doesn't need follow-up. But if in doubt, refer for advice and guidance. So hopefully that's of some help in assessing some histology you may get back from open access, which you may not be familiar with. But obviously, if you do have any issues, just use the advice and guidance service on ERS.